Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about discovering an oral treatment for severe alopecia areata. Our moderator this evening is Dr. Leon Kircik, who is the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences in Louisville, Kentucky. Our speaker this evening is Dr. Jennifer Soung, who is at Southern California Dermatology in Santa Ana, California. We'd like to thank our supporter, Pfizer, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will appear. If you're having technical issues, please submit your technical issue questions in the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We would greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, you will receive a certificate of attendance. And now, without further ado, I will pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone, and welcome to another IDEF's educational series. Just to start up, for a couple of points about our foundation, we are a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. We have served not only in the United States, but also in Canada, in Europe, Southeast Asia, as well as in Latin America. And those are some of our previous programs and previous speakers. Tonight, I am really excited to present Dr. Jennifer Soung. She is a board-certified dermatologist and the director of clinical research at Southern California Dermatology in Santa Ana, California. She specializes in medical dermatology, but especially in autoimmune conditions of the skin, and she was one of the investigators in the Louisville phase 3 clinical trials. So I'm really excited to present Dr. Soung, who is a great friend of mine and who's a great dermatologist. Please welcome Dr. Soung. Come on over. Welcome, Jennifer.
Thank you for that warm introduction, and thrilled to be here and so excited that all of you are interested in learning more about alopecia areata. So, as you all know, hair loss is one of those things that can be really hard. And for many years, we have not had great treatments. And many times when I saw my hair loss patient, my heart would kind of sink because I kind of felt like there weren't enough treatments to help make a difference or that would work consistently. Now, today we're just going to be focusing on alopecia areata. Now, if a patient came in with 1 or 2 patches, many of the times we know that's quite straightforward, either a topical steroid solution or injectable steroids, and many times it often spontaneously resolves. But what happens when you have that patient who has more than 50% hair loss or more extensive hair loss involving the eyebrows and eyelashes? Those situations are going to be a lot trickier. In my personal practice, while I was at the university or whether it was at private practice, I've tried many different treatments. I even tried contact immunotherapy, oral traditional systemics, like methotrexate or cyclosporin, but nothing really worked routinely. So today, I'm going to be talking about a new oral treatment option that has been shown in clinical trials to help with severe alopecia areata. So I'm thrilled that you are all here curious to learn more. And if there was anything that I have done in clinical research in the last several years that really brought joy to my patients and even to sharing that joy with my patients, it's certainly been hair loss. There's nothing more magical than helping a patient grow hair. Many times in dermatology, we're helping patients clear a skin rash or normalize their skin. But it is definitely a different and unique experience when you're helping patient grow hair. So in the next 30 to 40 minutes, I'm going to be talking about a new treatment that really gives hope and can potentially help your patient with severe alopecia areata grow hair. So let's get started. The title of today's presentation is Discover an Oral Treatment for Severe Alopecia Areata. Today's program is sponsored and paid for by Pfizer, and I am speaking on behalf of the company. The information presented in the program is consistent with FDA guidelines and is not CME accredited. I'm more than happy to answer questions that are consistent with the label. So the presentation is divided into 4 parts. We're going to start by talking about what have we learned about alopecia areata with the breadth of studies that have been conducted so far. Then we'll look at Litfulo in particular and look at the clinical trials to see what is the efficacy and safety. Next, we'll look at how to start the medication in your patient. So we'll look at initiation and monitoring of Litfulo, and then finally wrap up with what is the right patient for Litfulo. So here we start with an overview of alopecia areata, but before we get there, we want to know, where is your current understanding of alopecia areata? So we're going to start with 3 quick polling questions. The first question is, what is the mean reported age of alopecia areata onset? And we'll give you about 30 seconds to respond. Okay, so nice job. You guys did a great job. So you nailed it. The most common or mean reported age is really in the 25 to 36-year-old range. Closely followed after that is the teenage years, so 15 to 21 years old. Nice job. So happy to hear that you guys are already informed about alopecia areata. Let's go to the next question. What is the rate of spontaneous remission for patients with greater than 50% hair loss? Less than 5%, 6 to 10%, 20 to 25%, and then 35 to 50%. So before these large randomized controlled trials in patients with severe alopecia areata, I'm not sure we knew exactly where that percentage was, but now that we have data from the trials, we have a better idea of approximate number to give to our patients. So you see here, you guys nailed it again. So 6 to 10%. So that is exactly right. So when our patients ask us, okay, I have severe hair loss, in the clinical trials it was defined as 50% or more. If I did nothing, what would happen? And what we see that is that only less than 10% will spontaneously regrow hair. Nice job. We'll move on to our third question. Third and final question. How many patients with alopecia areata tend to progress to alopecia totalis or universalis? So 1 in 4 patients, or 1 in 10, or 1 in 15, and then finally 1 in 25. So we'll give you a couple seconds to consider where you think that lies. Is many patients ask us, well, what is my course going to be if I have a few patches, or I have more extensive hair loss? Will I lose all of my hair? So now we have an approximate number. So it is actually 1 in 4 patients will progress to alopecia totalis and universalis. And so I know many of you answered 1 in 10 or even 1 in 15. We've actually learned from the clinical trials that about 25% of patients can progress to totalis or universalis. Okay, so let's get started. I'm going to take over the slides. Okay, wonderful here. So let's review. So here we have our first slide on the epidemiology of alopecia areata and what we've learned from the clinical trials. And alopecia areata can really present at any age. While we know that the mean age tends to be in younger patients and young adults, it definitely has an unpredictable course and also can affect any age range. So I certainly had patients all the way up until their 60s and 70s in the clinical trials who still were wanting to seek treatment. On the right, you can see photos or images of different forms of alopecia. And I think this is really important. We have not had FDA-approved treatments for alopecia areata until 2 years ago. And so many times there was not a situation where it really required us to be definitive about the diagnosis for alopecia areata. You can see the image in A is patchy alopecia, clearly a clinical diagnosis, easy to make that diagnosis. Patient B has the band-like pattern around the scalp, so an ophiacid pattern. Now, patient C has a diffuse type of alopecia areata. So unless there was a history of round, smooth patches, that diagnosis can be a little more challenging and falls within that category of non-scarring alopecia. So in certain situations where the diagnosis is not clear and I am considering systemic treatment, I definitely want, and I do not hesitate to do a scalp biopsy to confirm the diagnosis. And then finally, D, this is a patient who has complete hair loss. And you can probably see that this patient also has eyebrow loss as well. And so again, depending on the patient's prior history, you may be able to put that diagnosis together and come to the clinical diagnosis of alopecia areata. So in certain situations, if I am considering systemic treatment, then I do not hesitate to do a scalp biopsy. So let's review briefly. We talked about the age of onset in the 25 to 36-year-old range, and then the rate of spontaneous remission. And I'll point that out when we review the clinical trial data, but what you see here is that patients with more than 50% scalp hair loss have low spontaneous remission rates. So if you do nothing, the likelihood of them growing back their hair is less than 10%. And then third, the risk of progression. We now know that patients who have severe alopecia areata, 25% can progress to totalis or universalis. Okay, so let's review briefly the pathophysiology of alopecia areata. As you know, it's a chronic autoimmune condition that causes inflammation at the hair follicle. On histopathology, we see the classic swarm of bees around that hair follicle bulb that we see in this cartoon picture here. But when we blow up that picture, what we see is that there are certain types of T cells that are involved. And these are now known to be CD8 T cells. And so we've blown up one of those pictures, and on these T cells are receptors for cytokines. And below that receptor are enzymes that pass signals from these cytokines from outside of the cell to inside the cell. And so these key cytokines are not only JAK inhibitors, but in this situation, we're also talking about new to dermatology called TEC kinases that are a group or family of hepatocellular enzymes that are also involved in the autoimmune inflammation pathways. So you see here that once a cytokine binds to that receptor, it passes a signal from the outside through the JAK enzymes that then stimulate transcription of more cytokines inside the cell. So we think this is the autoimmune pathway of inflammation in alopecia areata. So that constant cycle of stimulation of the cytokines at the T cells, passing the signals through the JAK or TEC enzymes and stimulating intracellularly more transcription of these cytokines causes the constant inflammation in alopecia areata. Now we introduce Litfulo, which is also known as ritlecitinib. And I'm going to start off first with the indication. It's most important to know how the FDA approved the medication. And what you see right away is one, that it's approved for severe alopecia areata. So one question I want to get you thinking is, how do you define severe alopecia areata? At what point would you start considering an oral medication for your patient who has alopecia areata? Next, we'll look at the indication. It's actually a kinase inhibitor. Remember how I referred to the JAK enzymes as well as the TEC enzymes. So we're going to take a closer look at that later. Litfulo is a kinase inhibitor that's indicated for the treatment of severe alopecia areata in adults and adolescents as young as 12 years old. So really amazing that we have an FDA-approved treatment in our adolescents who have severe alopecia areata. And I want to make a special note here for our adolescent patients, because I really think for adolescents who have severe hair loss, this can make a greater impact on this age range. And so I do think we have an opportunity to help these patients and give these patients hope and really change their life trajectory by helping them with their hair loss. Next, you'll see some safety information and boxed warnings that we're going to talk about in more detail, which have been applied to Litfulo as a kinase inhibitor because it also targets one of the JAKs. So this is the same warning we've seen for JAK inhibitors, the same box warning. Okay, so some key points and main takeaways I'm going to start with, and then I'm going to circle back to these. I want to introduce them here first. Litfulo is the first and only FDA-approved treatment for severe alopecia in both adults and adolescents, and I just said that. It's a kinase inhibitor, so it targets both JAK3 and TEC kinase family pathways. We're going to take a look at what improvement means in alopecia studies. Here, we're going to look at near complete scalp regrowth, defined as 80% regrowth, or in other words, the clinical trial tool that was used is called the SALT tool, so Severity of Alopecia tool, and that was measured as success was measured as less than or equal to 20. How the FDA came up with this number was because they asked patients, what does significant regrowth mean to you? And patients responded in a survey that 80% regrowth meant it was success. So 80% regrowth translated to a SALT score means a SALT score of less than or equal to 20. So just to review briefly, a SALT score of 100 is actually a bad score. That means complete hair loss. And a SALT score of 20 or 0 means complete regrowth, or a SALT score of 20 or less means 80% regrowth. And then we'll wrap up with looking at further efficacy beyond the primary endpoint at week 24, as well as the safety profiles, and then look closer at dosing. Dosing is easy and simple. It's one pill once a day, no titrations. Okay, so let's go back to that pathophysiology inflammation pathway that I showed you earlier and show you where Litfulo works as a kinase inhibitor. So I'm going to click through these briefly because we looked at them. So now you can see that green round molecule is ritlecitinib, also known as Litfulo. Now it's going to bind JAK3 and TEC and prevent them from activating the transcription of more cytokines inside the cell. So ritlecitinib or Litfulo is meant to disrupt the production of inflammatory cytokines in alopecia areata. So you see reduced transcription and reduced cytokine production. And ultimately, this is the proposed pathway of how Litfulo could possibly work. So next, we're going to look at the clinical study. So I have been an investigator for the clinical trials for Litfulo, as well as other JAK kinases for 5 years now. And it's been amazing to see the revolution and change and how it's evolved. What really impressed me about this disease state was how much need and the patients really wanted treatment. And to me, it was really my patients who showed and shared with me their stories about why and how much they wanted treatment. In fact, the studies for Litfulo started just about several months prior to the pandemic. Many of my patients had already started in the trials, and the COVID pandemic hit. And I would have thought, and I didn't know what to predict. Our research center stayed open. and patients wanted to come in. That's how dedicated and determined they were to continue with their treatment, because that's how much it meant to grow hair. And so what you'll realize in treating your patients with severe alopecia areata, losing hair is really a loss of self-identity. Okay, so let's take a look at how the clinical trials were designed and what kind of results we saw. So it was actually combined phase 2 and phase 3 dose ranging study. I emphasize that because you'll see on the left here, at the beginning of the study, there were over 700 patients. But because there were 3 other doses studied, we don't see that here. And we're only focusing on the 50 milligram group, which is the FDA-approved dosing. So to be in the study, you had to be 12 years or older, and you had to have 50% or more hair loss defined on a SALT score. So that's just looking at the severity of alopecia tool. And the clinical trial design was 50 milligrams once daily versus placebo for the first 24 weeks. After the first 24 weeks, everyone on placebo then switched to Litfulo 50 milligrams once daily. You'll see the primary endpoint was at week 24, and then the secondary endpoint was another 24 weeks later at week 48. So what did the results show? So briefly, I want to review the SALT tool. Now, I described it before, so you can see now the cartoon images. To remind you, SALT 100 meant complete hair loss. We normally think of 100% as a great score, for example, like on a test, but in fact, here 100% means complete hair loss, and a SALT score of 0 means complete hair growth. So, we have here a question. What do you think is this patient's SALT score? So the SALT score actually divides the patient's scalp into vertex, parietal, and posterior, and it's weighted. And so here, this patient actually has a SALT score of 52 to give you an example of what that might look like. So now, what kind of patients were included in these trials? I shared with you a lot of the patients because we have not had good treatments or FDA-approved treatments for alopecia areata, that many of these patients were really desperate and really wanted to try something new. I had patients who even called from other states or even out of the country wanting to fly to my research site just to be in the clinical trials. So what you'll see here, let's review the key inclusion criteria first. They had to be 12 and older, male or female. They had to have a clinical diagnosis of alopecia areata. There was no requirement for a biopsy. They had to have 50% or more of hair loss. Totalis patients as well as universalis patients were included in the trials. They could not have had any terminal growth or regrowth in the last 6 months. And this is important because we really wanted to recruit patients that had stable hair loss. As we know, based on our clinical experience, there's some patients who can have spontaneous regrowth, but we really wanted patients or tried to seek patients who had stable disease. Now, the last point is, and I get a lot of questions about this, is that the current episode of hair loss had to be less than or equal for 10 years. So a patient could have had the diagnosis of alopecia areata for 20 or 30 years. Now, we know some patients can have episodes of growth and regrowth and hair loss, but as long as they've had some regrowth, and since that last regrowth has not been more than 10 years, they were eligible to be in the trial. So certainly your diagnosis, your initial diagnosis could have been longer than 10 years, but the ideal candidate and the candidates in this trial were patients who have had some regrowth in the last 10 years. You can see the key exclusion criteria are clear and obvious. No other types of alopecia, no previous exposure to JAKs, no atypical herpes zoster infections. In fact, the adolescents all had to have their chickenpox vaccines. Okay, now to move along, I've talked about the baseline characteristics of these patients tended to be the patients who had the worst. So let's look at the right side of the chart here. You can see that almost half of patients, 46%, had totalis or universalis. And when you look at the mean SALT score, you see that 90% of patients, that the average hair loss was 90%. So certainly the majority of these patients had severe or very severe hair loss. In terms of the average duration since diagnosis was about 7. Their current episode of hair loss was usually around 2.5 years. You also see there's a small group of even older patients than 65, 3%. And we had our group of adolescent patients as well, and a broad, diverse population of white, Asian, and Black patients. Okay, so now we get to move on to the exciting portion is, well, how did these patients do? For me as an investigator, what's the most fun part about a clinical trial is really once the patient starts on day 1 with medication, you really don't know, are they on active or active medication or placebo, is watching them. And the joy that comes from seeing a patient with alopecia areata grow hair really comes from how excited the patient is. Now, I had patients who came in and just had a tiny bit of peach fuzz, and that was the first indication that they were growing hair, but thrilled. So let's take a look. Here we see our primary endpoint at week 24, and you see that more patients achieved a SALT score of less than or equal to 20. Now, we see that number 23%, and you may not think that is an impressive number, but what we do know is that it takes time to grow hair. So even in that just 6 months, 23% of patients grew 80% hair. That is pretty amazing. And I kind of think it's quite magical at times when you actually witness it in your patient. Let's see what happens with another 24 weeks of treatment. So we see now, after 48 weeks, 43% of patients are now achieving 80% regrowth or a SALT score of less than or equal to 20. So let's take a look at what this looks like in our patients. And this is where I think the joy is, whether it's the patient or myself, is pretty amazing that we can help patients grow their hair back. This is an adult female, 36. You can see at baseline, she has a very extensive ophiasis pattern. At week 12, and sometimes it's really hard to photograph, you can take a closer look and see there's that little fuzzy hair. It's not quite mature hairs. These are vellus hairs. And by week 24, she has really nice mature hairs that are growing in. So let's click through these pictures. We're going to look at all 4 sides of the scalp. And so you can see really nice regrowth. Now, all patients can have an individual or different response. Some patients grow their scalp first. Other patients can grow eyebrows and eyelashes first. Here we have another example of a 16-year-old boy who has totalis. And in this patient, you can see at week 12, maybe there might be some vellus hairs, but hard to photograph, and we're really not seeing it in the image. But by week 24, a really nice regrowth. Let's take a look at all the different sides. And again, you can see really nice regrowth at week 24, but he grew at a different rate, or maybe we couldn't photograph the vellus hairs at week 12. So now we're going to take a look at that safety profile. I know this is at the top of whether it's parents' minds or patients' minds is, well, if I'm going to be taking oral systemic, what kind of side effects can I expect? So here we look briefly at the boxed warnings. And because Litfulo is also a JAK3 inhibitor, you also have here the box warnings. And I think many of you know, I'm going to review briefly that where these box warnings came from was the oral surveillance study in a different JAK inhibitor, Xeljanz, and also a different population. These are rheumatoid arthritis patients who were 50 and older, who had 1 cardiovascular risk factor. And after 2 years, what we saw in that post-marketing survey was a trend towards more malignancies as well as thrombotic events and cardiovascular events. And this is where the box warning came from. So I will show you in the context of Litfulo and our alopecia areata patients what the important safety considerations are knowing these box warnings. Okay, before we look at the rates of these special adverse events or these adverse events of special interest, as well as the most common adverse events, I want to show you where the safety data came from. Now, remember I mentioned several other doses of Litfulo were studied in this phase 2b/3 study. So now when we look at safety, we're going to look at any patient who took any dose of Litfulo. So that's why you're going to see larger numbers here. So it's called the all exposure pool of patients, which comes from 3 randomized placebo-controlled studies, as well as a long-term study where patients continued on Litfulo to complete 3 years. So my patients, I actually had 40 plus patients in the clinical trials, are almost all completing the trial now. And you can see that means there were 1,600 Litfulo patients treated, representing more than 2,000 patient years, and more than 1,000 patients had more than 1 year of exposure. So that gives you a little more confidence in the robustness of the data. Here is just a brief slide reminding you that there are limitations and biases when you're looking at rare adverse events, because that can take longer to detect. So let's start by looking at the most common adverse reactions. So we're looking at the first 24 weeks, and any adverse event was reported more than 1%. So when you look at the top 3, I would confirm these were the exact same adverse events that I witnessed in my very own patients in the trials. Headache, diarrhea, and acne were the most common. So as we all know, acne is a signal in JAK inhibitors. Now, the headache and diarrhea often were mild and went away in the first month, really with continuation of treatment, and did not lead to discontinuation. When you look at the other most common adverse reactions, I think they are familiar to you and not anything that you wouldn't know how to deal with. I will make a brief comment about the elevated CPK. You can see that it just only mentions CPK and no muscle symptoms. So a CPK along with muscle pain or symptoms is then rhabdo. So I personally do not routinely check a CPK unless my patient is complaining about muscle aches. So now we're going to take a look at specific adverse events in the context of those boxed warnings. So you can see overall we're comparing Litfulo 50 versus all doses as well as placebo in the first 3 columns. And then the last column, we look at the all exposure pool. So when we look at just infections overall, when I'm thinking about a medication that is an immunomodulator, we can see numerically that it was a 0 in the Litfulo 50, all doses was 3, and the all exposure pool was 12. More importantly, opportunistic infections, if we're worried about significant immunosuppression, there was only 1 case. Now, I do in my personal practice offer patients the shingles vaccine prior to starting any JAK inhibitor because there is a signal with herpes zoster. You can also see thrombotic events were 0 in the first 24 weeks and 1 in the all exposure pool, and a small signal for urticaria. So in terms of laboratory abnormalities, we're going to review this, and I will show you what testing and how to monitor, what laboratory test to order prior to initiation and as well as monitoring. But here in terms of the context of labs that were actually abnormal during the trials, you can see here we'll be monitoring for a decrease in lymphocyte counts. But in fact, there was only 1 subject who had a lymphocyte count less than 500, and it appeared that age was a risk factor. So in terms of actual laboratory abnormalities with regards to the lymphocyte count, probably you can see according to the numbers here is uncommon. With regards to platelets, we also monitor platelets, and you can see that there was only 1 subject who had a confirmed platelet count of less than 100. No subjects had a platelet count of less than 75. Here, I mentioned briefly before the CPK, there were 2 patients that had elevated CPK in the first 6 weeks, and then there were some patients who had elevated liver enzymes that were more than 3 times the upper limit of normal, and that's why we're going to be talking about monitoring your chemistry. Okay, so let's move on to the initiation of monitoring. Here's some dosing considerations. It's 50 milligrams, 1 dose, 1 pill once a day, and no titrations. or adjustments necessary. It can be taken with or without food. Instruct patients to swallow it whole, do not crush it. And if the patient misses the dose, just to take it as soon as they remember, but if it's less than 8 hours before their next dose, then just resume at the next dose. Okay, here is the nice table for monitoring. So I first want you to focus on more on the right side of the screen. We're going to look at the column for prior to initiation and start from the top. So prior to initiation with any immunomodulator, you want to rule out any sort of chronic infection. So like your biologics, you're going to be checking TB and viral hepatitis. So you see that check mark. Next, we're going to be monitoring lymphocyte and platelet counts. So you're going to check your CBC. Liver function tests, you're going to check your chemistry. So I just add a complete metabolic panel to that. And then in terms of immunizations, no live immunizations with any immunomodulator, but I do recommend the shingles vaccine. The shingles vaccine is a non-live or killed vaccine, so it's okay for the patient to get it at any time during their treatment. I don't require that they get it prior to starting the LITFLULO, but I do say I recommend that you get it if you want it. In terms of malignancy, here just making sure that my patient is, depending on their age, has a primary care doctor who's doing their routine cancer screenings. Now, for the next time you're going to be checking blood work is at 4 weeks, because you want to check to see if there's a drop in their platelets or lymphocyte counts, and that's what you just do a CBC at week 4. And thereafter, the package insert actually does not have specific instructions. It leaves it up to the doctor. So now I'm going to share with you what I do in my personal practice, because we all need to start somewhere, and I do have experience from the clinical trials. And the nice thing about the package insert is that it does leave it up to your flexibility and how often, depending on your patient's comorbidities, how often you may need to check the blood work. In my personal experience, I like to check blood work after that 4 week. I will check every 3 to 6 months, depending on the patient's history and other comorbidities, any drug interactions I'm concerned about. And a young, healthy individual who does not have any other comorbidities, I'll just do 6 months, because that's really the next time point I'm going to evaluate if they've had any hair growth. Okay, so here are some other additional considerations. This medication has not been tested in pregnancy, and there are no recommendations for lactation. Now, with regards to women of childbearing potential, I do have a conversation. I think it's important to, just because many pregnancies are unplanned, is to talk briefly about what a woman's contraception plans are. I do not require my women of childbearing potential to have to be on oral contraception or some form of contraception, but as long as we've had that discussion. There are some drug-to-drug interactions. I rely on my EMR, and I already talked about the vaccinations. So the package does give us very specific instructions with regards to when you would interrupt a dose to recheck the blood work, or when you would have a hard stop and discontinue the medication. So you can see here, in terms of an interruption therapy, now in the clinical trials, patients can interrupt therapy for up to 4 weeks if they developed a serious infection, or here it says opportunistic infection. If your lymphocyte count dropped below 500, you had a serious event like a blood clot, or you had increases in your liver function tests where you were worried that the patient's liver function tests were going up and not down. So these are situations where you definitely stop and then recheck the blood work. Now, other situations where you would just totally stop the medication is when the platelet count drops below 50. Now, remember, I mentioned earlier, no patient had a platelet count below 75, or they have a severe hypersensitivity reaction, or a stroke, or a heart attack. Okay, so what kind of patients would be appropriate for LITFLULO? The very first question I asked when I introduced LITFLULO was the FDA-approved indication of severe alopecia areata. So what have you been thinking about? How would you define severe alopecia areata? We're going to go through these 3 patient examples. I'm also going to share with you what an expert consensus really came up with of alopecia areata experts. Here we have an adolescent whose name is Emily. She's 15 and she has 90% scalp hair loss. Her current episode is 1.5 years. Then we have John, who has rapidly progressing alopecia. 75% scalp hair loss. His current episode is 1 year. He was actually diagnosed 1 year ago. And then we have Maria, who's still unmanaged. She has 60% scalp hair loss. She's 33 years old. Her current episode is 2.5. She was actually diagnosed 7 years ago, and before she's actually tried a different systemic therapy. I don't think any of you would argue with me that these are patients who have severe alopecia areata who would be a candidate for Litfulo. But what exactly is that percentage that would prompt you to treat a patient or suggest Litfulo? Or is it prior failure of other treatments like a topical or injectable? And so I want to share with you briefly that there is a consensus statement from a group of alopecia areata experts who defined the different categories of mild, moderate, severe. And not only does it take into consideration the surface area of the scalp, so if a patient has 50% or more, that's automatically severe. But in any patient who has 25% to 50% and has an additional factor such as rapid hair loss, psychosocial impact, and eyebrow or eyelash involvement, and then tried other treatments including topicals or injectables, would then be upgraded into the severe category. Okay, so like we said, in these patients, definitely these patients would be a candidate for Litfulo. I want to remind you that Pfizer has a great access program and support for Litfulo. Unfortunately, there are some insurance companies who consider hair loss into one category as a cosmetic condition. It is changing, it's changed significantly in the last 2 years, so don't stop fighting for your patients. I highly recommend there's 3 things that you really want to document in your clinical notes to help get approval for Litfulo. One is the extent of hair loss. You don't have to do a SALT score, but the percentage of surface area of scalp involvement, what they tried and failed before, and you really want to mention the psychosocial impact. That's really important. For example, my patient doesn't want to go to work, or they feel bullied at school. All of these need to be documented and know. And then finally, eyebrow and eyelash involvement is really important to document. Okay, so this is my last slide, and these are the main takeaways. Let's review. Litfulo is the first and only FDA-approved treatment for severe alopecia areata in both adults and adolescents as young as 12. I showed you the data combined for the adults and adolescents. It's actually a kinase inhibitor, so not only does it inhibit JAK3, but it also inhibits the TEC kinase family pathway. I showed you that some patients achieved 80% or more regrowth at week 24, and with continued treatment, more patients achieved 80% regrowth at week 48. We also looked at the safety profiles that were consistent in both the adolescent and adult population and reviewed the dosing schedule. It's Litfulo 50 milligrams, 1 pill once a day, and no titrations or adjustments needed. So I thank you so much for being here tonight and allowing me to share my experience with my alopecia areata patients with you. And I certainly hope that you'll take this information to give other patients who have alopecia areata hope to regrow their hair.
Thank you, Jennifer. That was amazing. I learned a lot, and you know, I see a lot of patients, especially adolescent patients above 12 with alopecia areata, and it is really, really one of the most psychosocially impactful diseases, unfortunately, on our patients. So it's nice to have something that is approved for this condition. So we have actually a lot of questions, but I will sort of choose, since we are getting close to 8 p.m. on the East Coast. Before I do that, I'd like to thank our sponsor tonight, for Pfizer, for their support to make this program possible for us. So let's see here. The questions we have. So do you offer shingles vaccine in all patients or just when the age is indicated? You sort of mentioned that.
I did, yeah. I'm happy to re-emphasize. I offer the shingles vaccine to any patient who's 18 and older. because when patients get shingles, it's not often, they get really, really annoyed and mad at you. So
Yes.
I offer it, but I don't require it. And it's actually covered by insurance. So any patient who's 18 older on an immunomodulator, insurance covers that shingles vaccine.
Yep. A sort of, you mentioned these two. What's the youngest age indication?
Right. So to review, it's approved right now as young as 12 years old.
Perfect. Yeah. Actually, this is quite a few question times coming up from different people. How can we get the monitoring checklist somewhere?
Great question, Leon. What should we do?
I think that if they contact the Pfizer medical liaison, they will. I believe they will help them.
Right. I'm happy to, if anyone wanted to reach out to me to share that with you. But to review briefly, prior to initiation or at baseline, you want to check your hepatitis serologies, your TB, and then a CBC and a CMP. Now, what's unique about Litfulo is you don't have to check lipids. So then at week 4, you're going to check your CBC, that's it. And then thereafter, the package insert does not tell you how often or what tests to do. Now, in my personal practice, I will be checking a CBC, CMP every 3 to 6 months, depending on comorbidities or if the patient has had any changes in their other medical history.
That's very helpful. Now, I know you did answer this one too, but I think it's really important. Maybe you can sort of reformulate it. How is severe alopecia areata defined?
Great question. So now, based on the clinical trials that were conducted for Litfulo, in the phase 2b/3 trials, it was defined as 50% or more on the SALT score. So, which is roughly a correlation of the scalp surface area, although the SALT score is weighted differently for the vertex and the posterior scalp versus the parietal scalp. But overall, it's a general surface area percentage of involvement. Now, what I briefly talked about at the end of my presentation today is that there is a alopecia areata severity tool called the ASK tool that a group of alopecia experts came up with and published. I don't recall, maybe you know, Leon, if it was the JAD or or the British Journal of Dermatology, but the tool is published, and if you have simply a 50% or more scalp surface area involvement, it automatically puts you in the severe category. But if you have 25 to 50% surface area involvement with an additional factor, that can be defined as severe as well. The additional factors include eyebrow, eyelash involvement, if you've tried other topical therapies and injectable therapies, if you have significant psychosocial impact, and that's why I said it's really important for you to document in the note. I literally type in what the patient tells me. I won't leave the house because of my hair loss. I get bullied at school, or I don't feel human because of my hair loss. And so if you type that in the note, then the insurance company gets an idea of how this is impacting the patient. And then finally, rapid hair loss. So if you do that hair pull test and the patient is losing lots of hair and it's clearly the clinical diagnosis correlates with alopecia areata and nothing else, then that's also an extra factor that will put you in the category of severe hair loss.
So, you know, especially the eyelashes and eyebrows, it's quite impactful. It does really make them look, sometimes as they call it, I don't feel like human, right? It does have a lot of psychosocial impact, I think. And that does add that factor of, even if you don't have that 50% on the scalp, that sort of makes up for it, unfortunately.
Right. I'm glad you emphasize that, Leon, because I think we take them for granted, right? Eyebrows and eyelashes, we don't think that there's a function. And our patients with alopecia totalis will share with us that dust and irritation gets into their eyes, or when they sweat, the sweat drips directly into their eyes. And without eyebrows, eyebrows frame our face and make us look human. So, and in fact, just a brief story is that many of my adolescent boys don't mind if they have scalp hair loss because they can wear a base cap, right? They come in, they're just like still socially adjusting in high school, may not want treatments, they hate the injections, and they actually aren't motivated for treatment until they come back to me because they have no eyebrows.
Yeah,
they
that's
know.
so true.
Yeah, they don't look normal anymore. And so they come back to me, not because this up here, they're just like, I want my eyebrows back.
Yeah. You know, just like anything else in life, we never know the value of anything until we lose it.
A little bit.
Unfortunately, right? Now, the next question is sort of, you did touch upon it a little bit. Do patients need to fail prior therapy to be appropriate for Litfulo?
Absolutely. I mean, in the clinical trials, it said that you couldn't have been another JAK. Now, in my personal experience, my patients have certainly been on other JAKs, and not all JAKs are the same. So I think that if they have not tried Litfulo yet, absolutely, they are a candidate for Litfulo.
And then finally, how soon was a SALT less than 20 response seen in patients receiving Litfulo in the Allegro phase 2b and 3 study?
Great question, right? Our patients always want to know when am I going to see a difference or some hair growth. Now, and to set expectations, usually I tell my patients, well, it's going to take you 6 to 9 months to see anything. Now, I showed you the data from the clinical trials. The primary endpoint was at week 24, where we saw that 23% of patients achieved 80% regrowth. Now, on closer look, I didn't point this out, it wasn't on the slide, but at week 18, there was actually a statistical separation between the Litfulo 50 milligram group and placebo. So that would be the earliest place where you would start to see a response. And I think that was consistent with what I observed in my patients. However, that was a secondary endpoint.
Right. So I think we have we're able to answer all the questions we had. It's almost we're almost there. I thank you so much for that eye-opening lecture. It was amazing. I thank you again and enjoy New York City. I know you're there. So I thank you, everyone. Have a good night. And for our next program will be, can you pull up the slide since that we're done with our Litfulo program. So the next one, it's gonna be the latest approved indication for Cosentyx by Dr. Jennifer Sayo. I thank you so much, and hopefully I'll see you on May 30th on our next program. Have a good night, everyone. Bye-bye.
Good night, everybody.
Thank you.